So hello everyone, and thank you for joining us to learn more about value-based care. This is the final webinar of our 5-part series. The webinar today is being recorded and will be posted to our website. We'll be sending the recording and the slides to the participants. We have also linked the presentation of today's webinar into the chat box. I am Shannon Sari, Program Specialist with the National Rural Health Resource Center, which is providing this webinar today. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, you can press *6 to unmute your line. You can also communicate through the chat box, which is located on the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization into the chat box so we know who's joining us today. This really helps our presenter get a good feel of the audience on the webinar. Next slide, please. We have 2 pre-polling questions that we would like you to answer before we get started on today's session. Patricia, could you please pull up the first question? I am confident to unconfident in my understanding of best practices to engage community partners in the transition to value-based care. And then Patricia, if you just want to give a few more seconds. So it looks like 5% are confident, 68% are somewhat confident, 16% are neutral, 11% are somewhat unconfident. Thank you. Patricia, please pull up the second polling question. I am confident in my understanding of successful models for engaging community partners in population health initiatives. And then if you could give a few more seconds, please. So 5% are confident, 64% are somewhat confident, 23% are neutral, 5% are somewhat unconfident, and 5% are unconfident. Thank you all for participating in the polls. Next slide, please. In this session, participants will hear about best practices to engage community partners in the transition to value-based care and successful models for engaging community partners in population health initiatives. It is my pleasure to introduce today's presenter, Ms. Tony Ann Richard. Tony Ann Richard is Chief Executive Officer, of Healthcare Collaborative of Rural Missouri, a rural health network supported by the multiple funders, partners, and investments. Tony Ann's passion for rural health stems from her overall passion for serving those in need. The Healthcare Collaborative of Rural Missouri is the only healthcare network in the country that operates 4 federally qualified health centers. Tony Ann's expertise has been instrumental in successfully implementing and launching programs that improve access to care and healthcare delivery to underserved populations. I will now turn the presentation over to Ms. Richard.
Good morning, everyone. It's so nice to see all of you. I am recognizing some names and faces on today's webinar, and so that's exciting as well. For those of you who I have not met yet, looking forward to hearing more from you and learning from you. So I did ask Shannon prior to getting on this call today about questions. And so just to remind you, if you have questions as we go, please go ahead and put them in the chat. We'll do our best to address them as we go along the way, as opposed to reserving those for the end. Just kind of helps with some ongoing dialogues. So next slide, please. So a little bit about HCC. We were incorporated in 2004. I'm sorry, we were founded in 2004 and incorporated in 2006. I've been with the organization since 2007. In 2013, we opened up our first federally qualified health center. And so from 2006 until 2013, 100% of our work was devoted to being a rural health network and developing partnerships within our community. What this slide shows you is some of our strategic initiatives. And a lot of those were driven by the partners that sat around the table even back in 2004, 2005, 2006. We are a what's known as a vertically integrated network, which means we are a network of different types of organizations. So when our founding members were a critical access hospital, a community mental health center, a local public health department, division, area agency on aging. We also had some community leaders for economic development, some leadership within city and county government. We have added some additional members since then. We've expanded to include law enforcement. We also have some school-based leaders, superintendents on our board, all of which, not all, but the majority of which are also patients of our health center. And so these are some of the areas that we've been working on over the past 15 years. I think what's really interesting about the organization, way back when they were founded, that started out, everybody always wants to know how we started out. And we started out because there was such a shortage in dental and mental health professionals in our area of the state. And we knew that we weren't going to be able to recruit those individuals on our own. And so coming together as an organization to serve a larger area in terms of geography was really important. So we partnered with an FQHC at the time that was on our board to open a location within our service area and start addressing those oral health needs. After that, shortly after that, we added behavioral health services as well. Some of which, even though we had a community mental health center on our board and within our service area, there was such a shortage of professionals that adding it to the FQHC model was really a critical step. Next slide, please. So this is just a quick slide talking about kind of our timeline from 2009 through 2019, and then our value impact statement that we participate in with our primary care association. This particular value impact, because of the time that it takes to gather the data and put the information out here, this is actually from our 2017 report. We do have our 18 and 19 have been recently added to our portfolio, and these numbers continue to increase. So just, excuse me, looking at the timeline, some of the things that we identified as a network and as a community collaborative early on, and the things that we addressed early on, you can see here. Workplace wellness was really important. Our small businesses had concerns around having access to walking programs. We wrote a grant to get pedometers in our schools. We also worked with some of our funding agencies to put salad bars in some of our workplaces and in our school districts, because specifically in the middle schools, because middle school is where the obesity trending upward was a significant problem. And so putting these salad bars in the middle schools was an important piece. We also started back in 2010, we started our transportation initiative, which in the beginning was gas cards that we handed out through all of our organizations. We handed them out through the local public health department, the critical access hospital, the emergency room, the FQHC in our community, et cetera. We worked with those leaders to ensure that people that were needing a ride for different things, that they had access to that through this transportation program. We have since grown into having a staff driving program as well as a volunteer driver program. But that really started in 2010. The other thing I will say about the transportation initiative that was really important was we found that a lot of people were getting to their first appointment, but any follow-up, especially post-discharge, was a challenge. And we also had problems with people getting into specialty care. So we made sure that we were working with those specialty care referral partners as well during that time. We brought electronic health records into our communities. The hospital already had a plan in place for their inpatient services through a program called Meditech, which I'm sure many of you are familiar with. On the clinical and outpatient side, we were still in paper in 2011. We received a network development grant that allowed us to financially support the implementation of electronic health records in 3 of our hospital partners within our service area, as well as a private practice clinic, and also the local FQHC at the time. On top of supporting the transition to electronic health records from a technology standpoint, we also invested in training and implementation, improved workflows during that same grant period. You can see a few more things that came into play in these early days. We opened a clinic in 2013. 2015, we purchased our first mobile unit. And then it goes on to talk about some of the programs that we do from a social determinants of health perspective, specifically our warehouse program, which some of you have heard us talk about. It's a way for us to reach people in where they are, whether that be homeless, or we serve a lot of foster families, people that are taking in children at the last minute. They need beds, they need blankets. We gather things like dish soap, laundry detergent, all sorts of things that would actually be headed to a landfill. It's typically things that have not passed a certain quality inspection. Maybe one of the items is opened, maybe the box is ripped, etc. So retailers won't accept those things. So we work with a couple distribution agencies to bring those to the warehouse, and then we distribute those to other communities. And then we also do a lot of work with special populations. And so early on, we started working with migrant farm workers programs. We recently opened or transitioned a clinic from a privately owned developmentally delayed clinic to the FQHC setting, where we're able to serve patients with developmentally delayed patients with additional services, including dental, behavioral health, psychiatry, those types of things. Next slide, please. So this is a slide that talks about just a quick picture of some of our marketing in terms of outreach. But really the key to our outreach initiative is it is the key for us to be able to build relationships. And so the figure 6 and exhibit 2 that you see in the slide deck, I'm going to give you a link further on in the presentation to a couple of case studies that we participated in with the National Association of Community Health Workers. I'm sorry, NAC, the National Association for Community Health Centers. And also HRSA was a big sponsor of that initiative as well. And so these are two graphics that come out of that slide deck. And what I would like to draw your attention to is the fact that networking and these community based relationships take a lot of time. We spent in the early days, 2003 to 2007, they really spent time talking about breaking down walls, reducing turf war issues among providers. Sending a message that there's plenty of patients to be served in the community, making sure that we were trying to not overlap specific services, but also bringing new services in together as a group. Then what you'll see from 2008 until 2013 is really this idea around developing programs and services that integrate all of the partners. And so whether that be the hospital, the local public health department, the community mental health center, we did some stuff with our trails department, city trails department, county initiatives, putting together gap analyses where we could find out where things were missing in the community. And then our organization's responsibility, once those areas were identified, was to come together and find the funding to do implementation. One of the longest projects that we've worked on is actually a trail and a railroad right-of-way initiative that started back in about 2009. One of our railroads had donated some space, a right-of-way, I use that term loosely, to the city, one of the cities that we work in. And in order to make that, it was on the way to school for a lot of kids and there was no sidewalk. And so we've spent the last 10, 11, 12 years making sure that we can finish that sidewalk so kids can safely walk from where they live to school, as well as making sure that they're not walking on the road, adding some bike trails, things like that. So when we build our community-based plans, we're really focusing on what are the short-term outcomes, what are the intermediate outcomes, and then what are some really big stretch goals that we would like to eventually do in the community. The other exhibit 2 that you will see on there is just some of the key performance indicators that we have used over the past 10 years on measuring our outcomes. We have recently, we've just gone through a new strategic planning process, and while we've got a few different initiatives, our goals really have stayed the same. We want to be an employer of choice. We want to be a leader in the rural health network space. Fiscally responsible organization. We want to make sure that dollars in are maximized as we are sending dollars out. And that doesn't mean just for our organization as a whole, it means for the communities that we serve. And so dollars that come in, making sure that we're maximizing those to address those needs that we've identified with our other partners. Next slide, please. So in our strategic initiatives, what you'll find is that identifying partner roles and responsibilities was a really important piece for us. So this couldn't be that just HCC as an organization would come in and say, here's what we're going to do. In order to be a member of our organization, we wanted to set expectations of our partners as well. And in order to do that, we had to think about evaluation. How were we going to celebrate the wins? How were we going to adjust for our corrections? And how were we going to hold each other accountable? This wasn't just for the celebrations and losses for just one organization. This really had to be for the community. And I think that's where a lot of communities maybe get off on the wrong foot, is not spending the time up front to think about who's sitting around the table. Do you have the right people? Is there enough people? Is there too many people? What questions are you asking? Hiring some external evaluation folks to come in and facilitate a lot of those conversations is also super important. Having somebody local facilitate those conversations is really challenging because you come in with an immediate bias. It's amazing what we've been able to learn through the pandemic for what we can do in a virtual setting, not to let some of these roles and responsibilities fall by the wayside, but continue to bring them back to the table to say, hey, I know we're dealing with the pandemic, but where are we at on some of these other areas that we need to focus on? So I'm going to pause for just a second because I know I'm talking really fast, and see, Shannon, if anybody has any questions or clarifying points.
Nothing has come through the chat box yet.
Okay, great. So some of the things I'll go through on this slide a little bit more is in taking these areas, we developed the memorandum of understanding, memorandum of agreement with our partners. And part of those agreements, we really focus on those expectations. And so some of the expectation, and I'm happy to share our MOU with you, Shannon, if people would like a community-based MOU to get some of these programs started. But we talk about participation in meetings, making sure that you're present at meetings, making sure that you're bringing data as you come to the table. Where is it anecdotal? Is it verified? Really talking through some of those really hard conversations sometimes, right? Because people say, well, we need to bring a pediatrician into our community. This is an example of one of the questions or one of the issues that we've dealt with in our community. We had a group that really felt like we needed to bring in a pediatrician into our community. But in our service area, there's less than 100 babies born in any given year. And so while I understand the need to bring in a pediatrician, the concern was, could we keep a pediatrician busy? Is that enough babies being born every year? What is are they willing to take Medicaid? Are they going to see other, how old will they see kids? Are people going to switch from their current provider? Because what we didn't want to do was bring in a provider that wouldn't be successful and then would eventually leave in a very short amount of time. And so having data at the table and somebody who truly understands data to break that down to help facilitate some of those conversations. And we also felt like it was really important to be as lean as we could. So anytime that we receive a federal grant, we reach out to our other funding partners, whether that is at the state level or if it's a local foundation, even some of our community-based foundations. We would look for people to leverage their local dollars and to meet that federal match. And so that would allow additional programs and services to be developed within that same scope of work. Strong communications. Communication will always be the #1 priority for every organization on this marble that we live on called the world, because it can go really well or it can go really bad really quickly. And so being present as a leader, it was my responsibility in the early days. I would do check-ins with our community members every 2 weeks. We were still really small then. We had about 12 community-based leaders at the table. So that was pretty easy for me to manage. I would check in with them, make sure that not only were they still engaged in the initiatives that we had set for ourselves, but also were they engaging with each other. One example of that is during the beginning of the opioid crisis in our country, our small critical access hospital was in desperate need of a psychiatrist. And as you all know, psychiatry is extremely difficult to bring to a rural community. For the critical access ER model, the reimbursement was not going to be significant, and it wouldn't cover enough of the cost for the hospital to do it on their own. And so reaching out to some of our other partners to say, hey, could you use a day a week of psychiatry? Working with our school districts for different assessments that they were needing for psychiatry and dollars that they could access. And so we were able to bring a psychiatrist in that really was employed by the network, but worked with several other partners. And then it was a joint effort in terms of fiscal accountability for that. We have since expanded, and we have 2 full-time psychiatrists serving in that scope. And then we're in the process of considering adding a 3rd. And so sustainable systems and sustainable programs continues to be top of mind. Next slide, please. So definitions of safety net providers. We spent a lot of time learning what different safety net providers looked like in our community. Critical access hospitals, rural health clinics, hospital-based versus provider-based, federally qualified health centers. Additionally, local public health departments, some private practice in your community are safety net providers because they might be the only provider. And so what does their access look like? Are all of these places taking on new Medicaid patients? Do they have options for slide fee services, whether they call it a slide fee scale or if they call it something different? What is the access for somebody who doesn't have any type of insurance coverage to come into their community? So we broke off a cohort that was specifically around developing safety net providers within the community. And by developing them, our main purpose was to do an inventory of all of the services that were currently available, and also to identify the gaps that were identified during the conversations. And so we had some marching orders around what to do next. What do we need to consider in our next strategic planning initiative to figure out how we can meet some of those needs? Some of the things that came to the top of that is really some of the things that we're talking about in this group is the value-based healthcare models. What are they? What do they look like? What makes them successful? And the number 1 program that came out of that is how to maximize community health workers within these multiple types of providers and bringing the information back and serving the people. We expanded upon this initial group and have since added, I alluded to this earlier, since added law enforcement agencies to that mix, and how community health workers can help with reentry programs into the community. And so hopefully we are not tracking, people aren't going back to jail, making sure that people that are incarcerated for mental health conditions, are we talking with the jailers? Are we talking with the sheriff about what does that reentry look like that's a little bit different from somebody who doesn't have a mental health disorder, and what are we doing to prevent different types of actions? We also knew that implementing a community health worker in the emergency department, whether that be in person or virtual or access to, was really critical. Our emergency department was spending a lot of time, as many of you know, on non-emergent issues. And so identifying people that were the frequent flyers, people that were utilizing the emergency room for their primary source for primary care, medication management, people that were using the emergency room for their insulin needs, their other diabetic needs, was important, because not only would it help reduce issues in the ER, but it would also help to get people managed within their areas. So we deployed community health workers like they were candy for a while. Every issue that came up, we went back and said, well, is this a place a community health worker could go? During COVID, that became even more important, because we had so much access to people for testing, and now through vaccines, that connecting people with a community health worker that are dealing with a social issue or a health issue where they need additional services, allows our caseworkers to spend more time on case management and those types of things. And our community health workers then can really track people and help get them access to different types of services. I will also say on this slide that it is important to know your audience and make sure your audience knows each other during these conversations, because a critical access hospital that owns rural health clinics and you bring an FQHC to the table, you just need to really understand those dynamics. We've been really fortunate. I think HCC has been blessed in a lot of ways, one of which is we were a network. We were a community-based organization before we were a federally qualified health center. And so we were building relationships. We were doing social determinants of health before it actually had a name. Those were things that we were working on. So our relationships existed before we became an FQHC. And in fact, our local critical access hospital actually donated 2 of their clinics that were not going to survive the sequestration of the Medicare sequestration reimbursement model as hospital owned RHCs, because they were a for-profit they are a for-profit hospital, donated those clinics to the network to develop into FQHCs. And so there was this really nice marriage early on to have some great conversations and dialogue. What that did was that saved jobs, and it ensured that services existed in those communities where they had had a clinic for a really long time. I also think it's important that during these conversations, you make sure that whoever's facilitating them, make sure that they're safe. Make sure that you really work with people to get put their nerves at the door, if you will, and also maybe any perceptions that they may have about a particular organization or a particular leader in that same space. Next slide, please.
Miss Tony Ann,
Yes.
we did have a question come through.
Okay.
Have you used CHWs in combination with EMS in a community paramedicine model?
We have. We're still working on it. Yes. So the short answer is yes. We brought in 2 of our community in our service area. We serve 4 counties. And so we brought in 2 counties EMS directors to some of our conversations and talked with them about how to do a warm handoff on some of those calls to a community health worker. So the simple way that we've done it at this point is we have business cards for our community health workers to that the EMS staff can give to patients, especially ones that they're going to frequently that are not true 911 calls. Our community health workers can then help educate people on when to call 911 and when they can call the clinic. Additionally, we are part of HRSA's opioid response program, and we have put in with our ambulances also cards for our opioid referral coordinator. And so if somebody is taken by ambulance or is given Narcan on site, whatever that case may look like, this is also with law enforcement. Anytime there's an overdose issue, our opioid coordinator's card is given to that individual, and then we ask that they give permission for us to contact that patient. And so we've set up a collaborative memorandum of understanding. I'd also be happy to send that one over because it went through several layers of legal review to make sure that all of the partners around the table were comfortable with the language in there, specifically around privacy, any privacy concerns that may be taking place. But that has been a slow going program because not a lot of people that are that are substance use abusers They are not always comfortable with saying that they have a problem and that they want to follow up from somebody in the community, but it's definitely slowly taking place and slowly growing. And we've actually had some of our staff, our community health workers, do ride-alongs in the ambulance, on the ambulance routes, as well as on our police routes. And so they've been able to build some relationships that way as well. Okay. Next slide is continuing to talk about building these and sustaining the partnerships. And so I've talked about this quite a bit, excuse me, quite a bit, but having some crucial conversations at the beginning and then ongoing within your communities. So what you can see up here are some of the things that we used to build our conversation model. Transparency and honesty. We really wanted to make sure that we did our due diligence around compliance, because compliance for different safety net providers looks a little bit different. And so bringing in a healthcare attorney when needed to answer some questions. This is an example where we did for the memorandum of understanding, specifically around the ambulance and jail programs, because we wanted to make sure we weren't going to compromise anybody in this effort to bring new programs to the community. Also, community-minded leadership. I think the best way to make sure that you're doing this is to make sure that you have a vertically integrated table. And so who's sitting around the table? Is it just your healthcare leaders in the community? Because if it is, you need to go further. Who else? Is it your county commissioners, school districts, leaders in the community who maybe have retired, whether that be a sheriff, a deputy, a school administrator, somebody who's got some time and historical value within your community to talk about programs and services that maybe have happened in the past. Also being super mindful of duplication of services and appropriate place of care. What we didn't want was to build a huge kingdom around one provider. So we know that nobody can do it all. And so how do we keep those services rendered conversation diverse? It doesn't make sense for an FQHC to do an urgent care when there's an emergency room in our community that also offers urgent care services. And so sometimes what we found is actually some of the areas of services that people wanted to add, they already existed in our community, and we simply needed a marketing plan, which were things that the network could then step in and put together was a marketing plan. And then making sure that the governing bodies of these agencies are participating, whether it be through their leader or actually coming to some of the community-based conversations. So some of the areas of intentional collaboration that we did and we continue to do today is the Prepare Social Determinants of Health data source that is available online, and there's different tools for that. We use that internally in our organization, but we also use it externally with our network partners. So gathering information around housing is a great example. We have a housing crisis where we are. Our housing authorities love the information that we can share off of patient information is shared. And so we can talk about how to bring more housing resources into the community. Further conversation is whose responsibility is that, and what resources do they need in order to take that next step. UDS is another data source that is really comprehensive that can be shared among parties once it's been validated. And then also community health needs assessments for critical access hospitals. A lot of people are getting ready to do them now. I think they have to do them every 3 years. And so making sure that this group is participating in that and promoting it, whether that be through a survey, one-on-one conversations, however that hospital is determining how to collect the data, making sure that your group is pushing that out so they can gather more information, and then utilizing that information within your decision-making tree. We talked about shared workforce, and then existing and potential resources. You know, networks are perfect for looking for funding solutions for a diverse group of organizations that are trying to achieve the same thing. So next slide, please. Future models of care. We continued to talk about the changes in provider landscape, and the pandemic really pushed some of those issues to top of mind for us, because many providers had to close during the pandemic, whether that be for safety reasons or the staff were ill and the practice had to close for a couple of weeks. And so making sure that we were staying ahead of that ever-changing provider landscape, and also managing expectations for the community, monitoring the progress and performance. And you can only do that if you have those conversations early, set those expectations, monitor and report out. And then we use the IHI's PDSA model for our process improvement, and I highly recommend it. I'm sure many people are also on this call use that tool, but it helps you identify, once there's a problem, what are you going to do to rectify it? And is it a problem that needs to be addressed by this particular group, or is it a problem that needs to be directed to a different agency or a different organization? I mentioned the Rural Collaboration Guide, and you can see that link at the bottom, and that link in the PowerPoint should be, it should work. It worked on my end, and it worked on the one Shannon sent me. So if you need any help with that, please don't hesitate to reach out and let me know. But this is a really great guide that talks about our organization, as well as a hospital that merged with an FQHC, and it's actually the shared workforce is the CEO, and the CEO serves as the CEO for both the hospital as well as the federally qualified health center. It's a very unique model. I'm super jealous. I think it's great what their group is doing, and so you can read all about it in there. Also, some fantastic tools on data and ways that you can capture data from a community-based level without spending a whole lot of money, and feeling data isn't about a whole lot of things, it's about the right things. And so having your whole group involved in what are we trying to measure, you can always add people. I mean, you can always add information to that as you go along, but you have to have a place to start. And so try to keep it simple for what you're wanting to gather, and what are you wanting to report out, and then how do you set your movement from there. Next slide, please. So I just wanted to revisit this slide for just a minute and talk about collaboration takes time. So in this time frame that you see here, really 2007, we were an organization of about $150,000 FTE. It was myself and one other 0.5 FTE. Today, we are about a $10 million organization, and we have about 100 employees. And what's really important about that, I don't want to take anything away from our staff and board, because they've done a fantastic job, but we couldn't have created that without those beginning partners, without the hospital being willing to invest in the community and trust that the network could serve people in the community where they were not going to be able to meet those needs due to their own business model. Having the right leaders around the table. We were fortunate to have the CEO of the Community Mental Health Center on our board, who was a former CFO of a nonprofit hospital system. And so making sure that you have people engaged at that level will just really help catapult you into the next phases. And I'm really grateful. I'm really proud of that. It's probably one of the most proud things I am, of just that boots on the ground work that we did early on. We did not set out to be an FQHC. We didn't set out to be a 100 employee organization. I thought we would maybe have 10 staff, and we were going to continue to do this community development work into the long haul. What's important for us now is to not lose sight of that foundation. And so making sure that we keep these priorities moving, and that we identify new priorities along the way, and that we're not just focused on the FQHC, because while it is the economic engine of the organization and what we do, we wouldn't be here without these initial pieces of work. Next slide, please. And this is another figure that you can find in that collaboration guide. And it's just really the steps of how to get started. And so if this is something that you feel like, okay, I'm ready to bring a couple people around the table and think about what our needs are in our community and what I need to do to help be a leader in that space. These are the first 4 steps of how to get started. Super easy. Analyze your environment. The data is already there. Reach out to your hospitals, reach out to your local FQHCs, your local public health department. Just find out, what data do you have on the landscape of our community? What are things that your board has identified in the community that you as an individual organization can't achieve, but you would love to be part of the solution? Engaging with those potential partners, identifying them, asking them to help you identify additional people. Developing the collective strategy is where are those gaps, who needs to be at the table, and who needs to help carry those out, and what are those resources that are needing. And then ask for help. So the review of system requirements is really important from a compliance perspective, because you don't, like I mentioned before, you don't want to compromise what you're trying to do. You don't want to compromise anybody in this collective strategy. So making sure that you have the tools there to answer those critical questions as they come up, or that you have a way to follow up with them relatively quickly. And seek technical assistance when needed. I can't tell you how many times Terry Hill is on speed dial for me from the center. As well as many people. The National Rural Health Resource Center has a ton of services and resources for people. There's all sorts of organizations that are willing to step in and help people facilitate these conversations, get these things going, and then develop a funding strategy around that continued work. Next slide, please. So this is just my information. I'm happy to have one-on-one conversations with people. I'm happy to answer any questions, or if you're not too terribly far away, come for a visit if there's something I can do to help you. So thanks for the time today, and I hope you were able to glean some information that will help you in your community.
Yeah, thank you so much for the informative presentation, Ms. Richard. Before we jump into discussion and questions, if there are any, I just want to take a moment to pull up our post-polling questions. Please pull up the first question. Thank you. I am confident to unconfident in my understanding of best practices to engage community partners in the transition to value-based care. Then if you just want to give a couple more seconds, please. So 33% are confident, 58% are somewhat confident, and 8% are neutral. Next question, please. I am confident to unconfident in my understanding of successful models for engaging community partners in population health. Please give a couple more seconds. So 32% are confident, 50% are somewhat confident, 9% are neutral, and 9% are somewhat unconfident. Please pull up the third and last polling question. I am confident to unconfident that I will apply the knowledge gained from this educational training to assume risk and participate or continue to participate in value-based payment models to prepare for population health. Please give a couple more seconds. So 29% were confident, 43% were somewhat confident, and 29% were neutral. Thank you all for participating in the post-poll questions. Next slide, please. So now we're going to open it up for discussion and questions. If you have a question, you can either come off mute or you can type your questions into the chat box. So it doesn't look like we have anything coming through right now, Tony Ann. So if nobody else has anything else to add, thank you once again, Ms. Richard, for your time today. Also, thanks to all the Delta program participants for joining us. I hope you found this session beneficial. And as always, please do not hesitate to reach out to any of us at the center with any additional questions. I hope everybody has a great rest of your day. Thank you so much. Bye.